have okay, great. Now I got your attention. So we actually are very excited this morning that we have Dr. John Plastaras, who's here to give us this wonderful talk. How many folks have heard of ILROG? How many people know what ILROG is? Okay, that's excellent. All right, so the International Lymphoma Radiation Oncology Group has been around for some time. Dr. Plastaras is on the steering committee. He's an associate professor at Hopkins. I mean, not Hopkins, at Penn.
Penn.
Yeah, where are you? You're
still
Penn.
at Penn,
Yeah, still
yeah.
there? You haven't moved yet? Okay. So, and really, he has a background. He's a basic scientist. He is a chemist. He did his PhD first and then saw the light and came into medicine, and really thrilled that he has, because he's really been at the forefront of both GI medicine and lymphoma. Today, again, he's going to be talking about lymphoma, but also utilizing, appropriate technology, proton therapy, et cetera, how to do that. And so we are thrilled to have Dr. Plastaras here to kind of talk a little bit about the ILROG guidelines, and without further ado, we'll get you going. Thanks.
All right, thank you so much, Karen. I was really happy to see the weather report, 60 degrees and blustery, in case anyone wants to run out and hit the ocean waves. Terrible time to do it. It's time to learn about heme radiation. Who doesn't love that? All right, so these are my disclosures, just mostly around some committees, and as Karen mentioned, I am sort of heavily embedded in ILROG. It's actually been around for about 10 years now, but it's really coalesced the radiation oncology lymphomaniacs, and so I'm embedded in that. So there's a lot of bias that you'll see, sort of pro-ILROG stuff. I don't have any financial disclosures, but I do receive some support from Merck for a study that we're doing. So I want to talk a little bit about what guidelines are actually out there. I think it's important to know what the resources are. You don't necessarily need to memorize everything, but you need to know what's there so you can say, oh, let me go look that up. I am going to spend some time on individual diseases, including plasma cell diseases, try to pick out what I think are the pearls from there, low-grade lymphomas, Hodgkin lymphoma, and then talk a little bit about involved site radiation therapy. I think the first time I heard about involved site radiation therapy was when I got a call from one of our former residents who said, hey, what do you do for involved site radiation? I have this case. And I said, what's involved site radiation? He said, well, it's in NCCN guidelines. That's what I'm supposed to do. I was like, I have no idea what that is. Let me get back to you. Several months later, the ILROG actually did publish some of these guidelines, and I think that's kind of been the basis of why the ILROG guidelines have actually been one of the most downloaded PDFs from the Red Journal. And we'll get into a little more specifics around treating the mediastinum and diffuse large B-cell lymphoma. Okay, so there's a lot of guidelines out there for heme malignancies. I think the ones that most of us in the US use are NCCN guidelines, which are quite good. They're updated, and they have this kind of, you can do this, you can do that, you do that. Doesn't always tell you which to do, but they give you what are reasonable options, and they are updated very frequently, and that's one of their greatest strengths. There are other guidelines out there. ESMO has a lot of heme guidelines out there. COG, of course, for the pediatric diseases. And then another type of guideline that I am also involved with, which are kind of interesting, are these appropriate use criteria that used to live in the American College of Radiology, but then moved over to the American Radium Society. But those have sort of a different approach, case-based, and say, is this appropriate or not? And then, of course, the ILROG guidelines have been kind of cornering the market on heme malignancies related to radiation. So the ESMO guidelines, as I mentioned, there's a lot of them out there. I bolded the ones that might have something to do with radiation, just so you know what's there. NCCN have these broken out very nicely. Again, the bolded ones are the ones that might have something to do with radiation. One type of guideline that I wanted to highlight that doesn't always come to mind are these supportive care guidelines. ESMO has actually quite a few that go into some detail. And then NCCN have really nice guidelines around survivorship, which we have actually used quite a bit in developing in our survivorship clinic for young patients who are treated for like Hodgkin lymphoma and so forth. And then there's a lot of good palliative care stuff in there. But I think that supportive care side is not something that's in the ILROG guidelines per se. This is what the ILROG has put out there, and it's been evolving over the years. There's sort of an initial burst in 2014, 2015 to kind of get the main disease sites out there, and these are probably ones that most of you may be familiar with if you're familiar with them at all. And then we kind of had a little break, a huddle, and decided, okay, there's a lot of other more specialized things that we want to cover. And there's these other ones, including lymphoblastic lymphoma, CNS leukemia, extramedullary leukemia. You get the idea, kind of more specialized subtopics. One that was very interesting is this optimal use of imaging, kind of talking about use of PET scanning and so forth. So it kind of crosses all of the disease sites. That came out in 2019. And then just recently was published in the Red Journal is this mini atlas. It's called Making Every Single Gray Count, if you look at the title of it. But it is a mini atlas with several different kinds of disease sites, but not technically a guideline, but a nice resource. So we recently updated the ILROG website as part of the education committee effort to make it more user-friendly and slick. And one of the main things we wanted up there is to have links to all the guidelines. So if you ever want to know, is there a guideline for that? This is where to go, ilrog.org. I could pretty much just walk off the stage right now, right? But this is a really nice resource. I only recently discovered it myself. I was like, oh yeah, forgot about that. So this is the place to go. One of the major limitations of the ILROG guidelines, as opposed to the NCCN guidelines, is they are not really updated in a way that has been formalized yet. It might happen at some point, but these guidelines are not evergreen, so they do tend to age. And I just wanted to kind of put that as an asterisk on all of these things that you read in the guidelines, that it might not be the most modern thinking, so there has to be some adjustments. All right, you guys ready to talk about some specific diseases? Yes? All right, who has a microphone in their hand? Because we're going to do some what would you do type of thing. All right, so I want to do two different cases. So for plasma cell diseases such as solitary plasmacytoma or multiple myeloma, what's the most important OAR for myeloma patients? Anyone scream it out? John Wilson? Bone marrow. That's all they got. Almost all the treatments that you get for plasma cell diseases are marrow toxic. And there's tons of treatments that are coming out. Like every year they have a new thing approved. So unlike the old days when myeloma diagnosis was like, bam, you're dead, now you can go onto this, go into this, go into this, and people have serial treatments that they can use. And so as radiation oncologists, we have to be very, very aware of their bone marrow. All right, so with that in mind, case number one, a 61-year-old man, newly diagnosed, so he's in sort of inning number one of his myeloma. He has a path fracture at T11, but his MRI also shows some infiltration of T9. He definitely has back pain. He's really incapacitated. Okay, these are the fields that I put on. So I decided to treat T9. What dose and fractionation would you use? 20 gray? Yes. 20 gray and what gray fraction? 2 gray. And 2. All right, so we have 20 and 2. Any other ideas? 30 gray and 3 fractions. Because you're worried about spinal cord compression? 10 fractions, so 3 per fraction. Any other ideas? 8 times 1. I heard 4 times 5. This is why it's really hard to write a ABR question on what's the right dose for a myeloma. Because actually, I would say all these things are reasonable. I would take issue with the 3 times 10, John, because I feel like that's too high of a dose if you don't have spinal cord compression, but we'll get to that in a second. Okay, so we'll put a pin in that. Second case, 62-year-old man, solitary plasmacytoma of the nasopharyngeal wall. It was less than a centimeter, and it was resected. We don't have really any good information about margin status. We asked the pathologist, and they said, well, you know, it wasn't really an oncologic procedure, so they wouldn't commit to it. So we presume that the margins are probably positive because they didn't really know what they're getting into. All right, so what dose would you give for that? 45 and 1.8 gray fractions, okay. 3,000 in what grade? In 2. Any other ideas? 50 gray? Okay, all right. So I'll tell you how I treated these people. I did 2.5 times 8 for the first guy. I don't like the 8 times 1 or 4 times 5 necessarily for someone who's in inning 1, but those I think are totally reasonable. And I don't know that 2.5 times 8 is actually any better on the marrow than 3 times 10, John. So I don't think that what you said is, wrong per se. But I try to go a little bit longer and lower early on. For the solitary plasmacytoma case, I treated this guy with 40 gray in 1.8 gray fractions. You guys are probably making fun of me here for using proton therapy, but this is the reason he came to Penn in the first place, because I really want protons. And somehow we got it approved. All right. So these are the guidelines for plasma cell diseases. They came out pretty recently. Dr. Sang ran the show on this one. He's a real expert. I want to highlight what doses they recommend for different types of solitary plasmacytomas, because they kind of break it out into large and small, so greater or less than 5 cm for bony plasmacytoma. Remember, the bony ones are the ones that are more likely to progress to myeloma. So for small ones, they say 35 to 40, which of note is less than what NCCN had been recommending. So we're kind of coming to these lower doses that you had suggested down here. For a solitary bony plasmacytoma that's bigger than 5 centimeters, going to 40 to 50 is reasonable. 45 would totally be reasonable. And then for extramedullary ones, so not the ones in the bone, but like in the nasopharynx, 40 to 50 gray, leading towards those lower doses if it's small, well-defined, or post-excision just with positive margins. So for those of you who are doing, is anyone doing SACME for this? All right, I'm not going to say what is the right answer, but Michael Jackson is really interested in the dose that you give for small bony plasmacytomas. Okay. So we talked a little bit about myeloma plasmacytoma doses. In the guidelines, they say 8 to 30 gray with all these different options there, sort of preferring the 8 times 1 for people who have a poor predicted survival and just bone disease. If you're doing larger volumes, going a little more fractionated, higher doses, or if you're overlapping and retreating, then we tend to fractionate a little bit more, which is not uncommon actually in myeloma. If you do have epidural disease or cord compression, the guidelines said 30 gray and 10 to 15 fractions. I will say that this is sort of potentially aging a little bit. There's definitely some trends towards lower doses to mitigate marrow toxicity. Again, this is not guideline stuff yet, but Leslie Ballas from USC has a multi-center ILROG trial open looking at 2 gray times 2 to palliate bony pain, which is interesting. We'll see what that shows. But there's some push to maybe even use lower doses for cord compression. I've actually used 2.5 times 10, and I don't really feel that nervous about it. But I would probably not do the really low BED ones if you have true cord compression. Dr. DeBaj's group, MD Anderson, just published this paper sort of making this push for lower doses, and this is probably where the field is going. By the way, that cheese there is a sign of when things are aging, so just as a little cue. If that wasn't obvious, yeah. Okay. Let's do another case for low-grade lymphomas. All right, so I saw this 31-year-old man with a left submandibular mass. It was initially FNA'd, and it was like maybe compatible with a CD5 positive mature B-cell neoplasm. People weren't really satisfied with that diagnosis, so they went to one of our ENT docs. And if you know anything about Penn, the thing that we love more than proton therapy is TORS surgery. So this patient got TORS, I didn't see him before he got this TORS, just FYI. He got TORS. They did a piecemeal resection, took it out in 3 chunks, and he had a speech defect with tongue numbness and facial numbness, which was awesome. But he had a diagnosis, and they called it marginal zone lymphoma. So this is an extranodal marginal zone lymphoma of the submandibular gland, sort of resected in 3 pieces by TORS. All right. How did you guys manage this patient? I heard someone say radiation. All right, what dose and fractionation? 24 and 2. Thank you, Dr. Ojerholm. All right. Anyone want to observe this patient? I'll be honest, I was tempted to observe this patient because, it was like resected and it's extranodal. I think this is the one setting where you can use surgery to treat a lymphoma where you have a sort of glandular, like a salivary gland, marginal zone lymphoma that's been resected completely. I think because this was done piecemeal, I wasn't really comfortable with that. I did actually recommend radiating him, and I did use 24 in 2-grade fractions with IMRT. All right, so does anyone know who this gentleman is? Who said that? Bobby Brown, right. Thank you, Karen. Yes, is one of 3% of African-American radiation oncologists. She knew her Bobby Brown trivia. So why did I put Bobby Brown on this slide? Dr. Gillespie? Why Bobby Brown when we're talking about volumes for low-grade lymphomas or settings where we're using radiation alone? It's not because I'm cruel, right? Yeah, great guess. It's because it's your prerogative, right? It's your prerogative to define how much nodal elective volume to use. So again, when this guideline came out, I got a lot of calls from former residents saying that I don't understand what we're supposed to do when we're using radiation alone. So what are those settings where we're using radiation alone? So remember, this is if you have stage 1 or 2, like follicular lymphoma, stage 1E marginal zone lymphomas, like the case I'm showing, or stage 1, 2 nodular lymphocyte predominant Hodgkin lymphoma, which we'll do in the e-contouring session. So you're doing radiation alone. So you're not just treating the gross disease. They're not getting any chemo. You're responsible for the whole curative package. So you do some extra nodal radiation, but it's very unclear what that is. And this verbiage I took from the guideline, but I'm not going to make you read it because it's basically unclear. We did get a little bit of follow-up data in a presentation from Astro last year, where the British Columbia retrospective of all their follicular lymphoma patients, where they've been using what they were calling like sort of involved node as opposed to involved field. What they mean by involved node is if you're electively treating less than 5 centimeters from the mass itself. So that's what they called involved node or involved site. So we don't really know what that means, but less than 5 cm is probably okay. The way I do this is if I'm bumping up into something that is a critical structure. So this is a patient with a, can you see this mouse? My pointer? Is there a better pointer? Oh, here we go. Okay. So sorry for the people on that side of the room. You know what, I will use the mouse. All right, can you see that? All right, yeah, so this is gross disease. He also had a groin node, but he had this external iliac node. So how far above did I draw my CTV? I actually didn't know, so I had to go back and measure this. So I did about 3.5 cm above as you're going up in the bowel. I will tell you that I used like 5 cm of CTV going down into the inguinal canal because I was like, the toxicity of that is not going to be as great. So I kind of used my elective volumes based on what OARs I'm worried about and what the clinical setting is. So yes, use your judgment, talk it out with your medical oncology team, or phone a friend. By the way, one of the other things on the ILROG.org website is all the steering committee members and all the council members. I would encourage every single person in this room to have an ILROG buddy if they have questions about cases. It's always good to talk these things through. One other bonus planning tip, similar to what Dr. Wilson pointed out about myeloma patients, follicular lymphoma patients, if they are going to recur, are going to want systemic therapies that are marrotoxic. So I try to be careful about marrow when I'm planning a stage 1 case. Okay, so when you're dealing with these non-nodal, non-Hodgkin lymphomas, so salivary gland, thyroid, brain, there's a lot of random things that are out there. These were all consolidated into one pretty comprehensive one. It's not totally comprehensive, but it's pretty good that looks at all these random sites. So this is, I think, probably the PDF that I email to people most often. I'm just like, yeah, it's in there. For skin stuff, there's an entire one just devoted to skin. So these 2 guidelines are actually pretty good for covering these random non-nodal, non-Hodgkin sites. So just some dose considerations. For indolent nodal lymphoma stage 1, 2, it says 24 to 30 gray. I prefer 24 gray. For marginal zone lymphomas, it depends a little bit about on the site. For salivary glands, if you can stay just below the dose that you're going to cause xerostomia, it is nice. For gastric, the standard's 30 gray and 1.5s because that's just what they did at Memorial Sloan Kettering for a long time, and we've all followed that. But we may be able to get away with lower doses. That's not in the guidelines yet. And then the orbit, we tend to do 24. Some people are trying to push for lower doses, but if you want to cure them, 24 is still like kind of the right answer, 24, 25.5. And other sites are kind of range 24 to 30. If you're dealing with a pure palliative setting, 2 grade times 2, the old boom boom, love it, works great. Patients do great with it. And then if you're palliating cutaneous T-cell lymphoma, there are some data to suggest that 4 grade times 2 is better than 2 grade times 2. I will also say there are data for 8 times 1 if you just have that patient that doesn't want to come back for a second treatment. 8 times 1 is also acceptable. And then if you're doing total skin, not many people are doing that anymore, but I think the new standard is to go towards 12 gray, so really low doses for total skin. So if you're ever referring someone, it's not like the 9 weeks horrible thing that people used to do. You can get in and out in 3 weeks, and some people are even doing a little more hypofractionating and can do it in 2 weeks. So find someone who knows how to do total skin so you can refer those patients. All right, so those of you who are doing SAMs, Artie is loving the low dose for indolent nodal lymphomas. Okay. Hodgkin lymphoma. Very briefly, the first thing you do for limited stage is to decide if they're favorable or unfavorable. This is sort of the German style. And if they're favorable, you can do this ABVD times 2 and 20 gray. Not too many patients actually fit that, but it's great if you can do it. But it's only for those patients that strictly meet those guidelines. Early stage unfavorable, ABV times 4, and then 30 gray. And then in the advanced setting, there is probably some role for radiation. We tend to use it when there is very, very bulky disease or an incomplete response. And then the relapse refractory setting, kind of things are all over. But fortunately, there is a new guideline that's specifically dedicated to relapse refractory Hodgkin lymphoma. These patients can be quite complicated in terms of what they've been through. So that's the guideline that I go to for these relapse refractory patients. One thing that's complicating everything and sort of guidelines aging quickly is all the brand new biologic developments. So in Hodgkin lymphoma, PD-1 inhibitors are gangbusters. It's like it's the best site for PD-1 inhibitors. The response rates are highest in Hodgkin lymphoma. Who knew? Okay. The ERTC H10 trial has put a little bit of a twist on this. So if those of you who love the NCCN guidelines, there's like a whole nother page of doing this totally different paradigm. The things that I like to point out for that is there are some patients who might look like they're unfavorable according to German, but you can actually sneak them in as favorable according to ERTC, and they can get 1 less cycle of ABVD. So the favorable patients on those, if they're like favorable by ERTC, unfavorable by German, they can get ABV times only 3 and then 30 gray. So that's a little nuance that I want to point out for you guys. And then the other thing that's interesting about the H10 trial is if you don't get a complete response after PET2, there are some data to suggest that you might escalate. That's not usually our decision, but it is one of the things that's been layered onto the H10 and the HD10 and the HD11 studies. So the relevant guidelines for Hodgkin lymphoma, they have the ones that came out in 2014, which is sort of like the upfront treatment. In 2018, they did this relapse refractory one that I mentioned. And then the guideline on proton therapy, I think, is actually pretty useful, mostly because of the dose constraints that are in there. You don't necessarily have to have a proton center to enjoy that guideline. And then this imaging one that I mentioned before kind of cuts all across. All right, so let's do a case. And there's going to be a question, and I really want everyone to commit to an answer here. So the question is going to be, what does your CTV look like? But this is the case. A 25-year-old woman had ABVD times 4 for unfavorable risk Hodgkin lymphoma. The patient was simulated in deep inspiratory breath hold position, and then we fused the PET. So you guys can probably appreciate how awesome this fusion is. So yes, there was probably some disease down here in this part of the mediastinum, but this is actually some gross disease up here. So the disease was here, and then there's some stuff over here, okay? But they had metabolic complete response. All right, so you guys ready to vote on a CTV? All right, so just take a minute to look at it. So this is with the involved site paradigm, is what I'm asking about. I don't have the audience response system, unfortunately, so we're going to have to do good old-fashioned show of hands. All right, so who likes A? Who likes A? Okay. Who likes B? Okay. Who likes C? No one likes C. All right. And then, does anyone like D? All right, so I think we're kind of caught between A and B. I think this is one of those things where as you scroll through, you may be able to differentiate what is actually gross disease or not. Because the fusions are not that great, because when you do breath hold, the anatomy changes, I tend to do something that looks more like B, because you don't really know all the time. So when we think about involved site with combined modality, this is the exact verbiage out of the guideline, and it's actually not that bad. You're trying to basically account for the shrinkage, taking into account those structures that weren't ever involved, so the lungs as they squeeze in. But if you don't have a great fusion, then you tend to just be a little bit more generous. One other little random point is this connecting of the CTVs if the volumes are less than 5 cm apart. That's in there as well. So this is where I like this this new mini atlas. These are the sites that are there. They don't have mediastinum published yet. Hopefully we're going to get some additional sites in there, but there are some nice examples in the mini atlas. So anyway, for those of you who are doing SACME, there's some verbiage. Okay? Thank you, Lizzo. All right. Another case. 21-year-old, unfavorable risk, classic Hodgkin lymphoma. Had 3 sites of disease, so they're unfavorable by German criteria. There's disease in the upper mediastinum bilateral superclave. Got 2 cycles of ABVD, complete metabolic response by the Deauville criteria, so a 2 on that 5-point scale, and ended up getting 2 more cycles without the bleo because maybe the patient coughed or something. All right, so how would you simulate this patient? Carefully, I like that. Dr. Green, any ideas? Breath hold. Do you guys hear that? Who has breath hold in their facility? Do you guys use it mostly for breast? All right, who has done breath hold for like a mediastinal case? All right, good. So if you have it for breast, if it's set up for breast, I think I'm not going to say it's easy, but it can be adapted for mediastinal cases, and I definitely encourage you to do that. The use of deep inspiratory breath hold has been shown to decrease dose to the heart and lung, and it does sort of eliminate motion. So we like breath hold. One of the things that's kind of an interesting debate in the lymphoma radiation world is like, which is more important, breath hold or proton? This is kind of a comparative plan that showed, comparative study that showed that if you're doing IMRT with breath hold, you get about the same, marginal improvement as just with proton therapy alone without breath hold. So I will say at Penn, we try to do the ultimate. We do breath hold and proton therapy. But if you don't have access to proton therapy, then just do breath hold. Okay. So how do we minimize doses to OAR? So this is going to be kind of just some tips. Use breath hold, yes or no? Yes, if you can. Planning, 3D versus IMRT versus proton, kind of depends on what you have available. I think that 3D is probably not the way I would treat most patients nowadays. Proton therapy is still obviously a little avant-garde. And then the big thing that I think is useful when you're doing IMRT planning is actually putting on dose constraints for the substructures. So here, if they're doing a mediastinal case, would contour like left coronary artery and LAD, or valve, a few people. So if I can make one request for you guys when you leave here, can you just start contouring those things? I know it takes time, but if you can at least, at minimum, do the stuff that's most important. I mean, when people get heart attacks after radiation, it's like to the left ventricle. So, the aorta, the left main, LAD. If you just contour them, then your IMRT is going to be able to avoid that. Mean heart dose, yeah, that's all important and everything. But there's a great article that Brad Hoppe wrote called The Meaningless Meaning of the Mean Heart Dose, meaning that if you're doing IMRT or proton, like the mean heart dose doesn't really reflect what the coronary substructures are getting. So I would really love for you guys, if you're treating someone who is going to live a long time, to contour those things. It doesn't take too long. If you don't have the time, you can ask one of the Penn residents to do that. I'm sure they'll be happy. So as I mentioned before, one of the best things in the proton guideline. So this is actually published in Blood, which is pretty cool. So this is the one guideline that broke out of the Red Journal. But the thing that is, I think, most valuable in there is these dose constraints. These are what we use in our templates for mediastinal lymphoma cases. The ones for the coronary substructures, I will admit, we kind of picked out of thin air, but we do use a mean of 5 gray for the coronary arteries and valves. So, it's sort of aspirational, but we do have this kind of idea of optimizing and then unacceptable. So for those who are doing the CME questions, the coronary dose of mean of less than 5 gray is very important. Okay. Thank you, Zach Galifianakis. Okay. So in this era of stricter dose requirements, it's not okay to just say, oh yeah, that's, acceptable, it's fine. You got to be a little bit stricter with yourself, because the med-oncs don't like to refer these patients. But if you do everything you can do, then I think you can convince them that these patients are worth referring. Combined modality is potentially a good option for them. ISRT has really changed the face of this. I mean, we were treating much lower volumes. This is not what people read about from the 1970s. It's okay to use sort of your technology because you're doing contour-based planning. So it's fine to use IMRT and rapid arc and all that other stuff. But you just have to be very careful about your dose constraints. DIBH, I do think is very important, especially for upper mediastinal cases. I will say that stuff when you have cardiophrenic nodes, not so good because you're basically just moving the cardiophrenic node down. And then getting involved early on is really important. If a case looks really, really horrible for radiation, you should tell the medical oncologist that up front so they can either do 6 cycles or do something that like the rapid approach where they're just doing response-based treatment and omitting radiation. Say, I don't want to treat that patient. I think you start to get some credibility. I do use the takeoff of the left main coronary as sort of a thing I teach the med-oncs to look for, and they now are pointing this out in tumor boards, like, oh, it's below the left main, so that's probably not going to be a good radiation case. I'm like, amen, sister. So, yeah. All right, so let's change gears a little bit. Diffuse large B-cell lymphoma. This is a guy that I saw. He's actually an FBI agent. So the stakes were really high when he came to see me after he completed 6 cycles of R-CHOP for a stage 4 diffuse large B-cell lymphoma. This was like not MYC amplified. This was just a regular diffuse large B-cell lymphoma. He had initial involvement of T5, and then this bulky retroperitoneal mass that measured in conglomeration over 9 centimeters. So after 6 cycles, he's had a complete metabolic response. Does this guy need anything more? Dr. Yunus, this is a harder case. What would you do? Just the bulky site? Would you go after the bony involvement too? It's its only site of bony involvement. You would? Okay. You guys agree with that? When you're thinking about these aggressive non-Hodgkin lymphomas, these are the relevant guidelines that are out there. There's one that from 2014 that talked about just nodal NHL, more general. The extranodal ones that I mentioned before with all the subsites. And then the relapse refractory guideline, which came out in 2018, and then the imaging one. In general, the role for radiation in aggressive non-Hodgkin lymphoma, and mostly we're talking about diffuse large B-cell lymphoma here, is if you're doing limited stage patients using the limited chemotherapy where they're doing, say, like 3 cycles of chemotherapy, you add radiation to that, 30 to 40 gray. Sometimes they're going to be bulky to start with, or have skeletal involvement, or have a partial response. Even if they get full dose chemo, so 6 cycles of R-CHOP, we still may have a role. Those 3 indications that I mentioned, so partial response, bulk, and the definition is greater than 7.5 cm, or skeletal disease, those things are all potential indications in the advanced stage setting after full dose chemotherapy. It's always a little bit of a discussion, risk versus benefit, but this is one of those things where I always raise my hand in tumor and I'm like, that's for me. And we've kind of gotten to the point where people now know 7.5 cm, oh, we should have John look at that patient. The role of radiation in the relapse refractory setting is very complicated. Again, I would direct you to that guideline because every case is quite different. One thing that I think is probably the patients that most people who are kind of out there actually practicing and not at a center where we have like a really good relationship with our med-onc is in the palliative setting. Like a lot of people I talk to, these are the only patients they get. So I think that this is an area that we actually need some more guideline development of specifically how to treat lymphoma patients for palliation, because these situations are all a little bit different. So these are some dose considerations. I want to make sure we have time for our e-contouring, so I'm going to kind of highlight at least the one situation that we mentioned. If you have someone who has diffuse large B-cell lymphoma and they've had a complete response, 30 gray is okay if you're DOVA 1 to 3. Now, we used to always treat patients with bone disease to a higher dose. That's no longer true. If they have a metabolic complete response that you can document, 30 gray is okay. There is some push to doing even lower doses that they're working on at Duke, but that's beyond the guidelines right now. Okay. This is how I treated this patient. I treated the mesenteric mass using rapid arc CBCT daily to 30 gray. I actually treated that skeletal mass to 20 gray based on some of the early data out of Duke, and they recently published on that. But I was just trying to avoid treating this guy's mediastinum to a high dose, because it's very small volume disease. All right, so how am I doing in time, Karen? Okay, so here's another case I wanted to share with you, and this is a little bit of a preview of Dr. Wright's scientific presentation for CAR T-cell. But this is a patient that was referred to me who had really refractory, aggressive CD10 positive B-cell lymphoma, had been treated with our EPOC, so that's kind of the stronger chemotherapy, and then progressed almost right away, then got a cycle of salvage chemotherapy, our DHAP, and had sort of progressive disease. And this patient was recommended to get CAR T-cell. They basically said, all right, she's chemo refractory, I'm not gonna give any more chemo, let's go to CAR T-cell. So this is a situation that we're encountering at Penn because they love CAR T-cell there, but I know that in talking with a lot of people out there in the world, this is sort of becoming like everyone has to deal with things like, oh God, what do I do with a CAR T-cell patient? So this patient was referred for bridging. Her mass was painful, so what we ended up doing for her is treating with rapid arc and doing kind of this simultaneous infield boost plan. We treated the GTV to 44 and the larger PTV to 36. No one really knows what to do with these patients. It's an area of sort of active investigation and kind of doing what makes sense. So if it's the only site of disease and you have the time, we've like these longer courses. If you don't have much time, then 4 grade times 5 is what we've used a lot of. But I think Dr. Wright is going to present on this afternoon. So again, the guidelines on what to do with large cell lymphoma patients are already aging. So the relapse refractory one doesn't really talk about CAR T-cell. So they're already aging as fast as they come out. And having to sort of adjust to these things, again, I think points to the importance of having an ILROG buddy. The trend of biologics in heme malignancies has, I think, been faster than even the solid tumors, which seems like it's a dizzying array. But in the heme malignancies, I think it's going probably at twice the speed. And having to deal with this environment means that we just have to know more about them, just interface more with the medical oncologist, and have really good multidisciplinary discussions. So future of ILROG guidelines. So I don't know exactly what's happening next. I'm not in charge of the ILROG guidelines. Lena Specht from Copenhagen is in charge of them. But some of the things that I think she's planning on doing is trying to establish a mechanism for updating them so we don't have to keep on putting cheese on our slides. We would also like to make them a little bit easier to access point of care. Another big complaint about the ILROG guidelines is these long, flowing verbiage, and really what we want is a table, right, that we can just bring up in front of the patient, point to the square that the patient's in, and say that's what we're doing. So we're hoping to improve accessibility there. And then some of the unmet needs, I think I mentioned palliation is one where I'd love to see an ILROG guideline on palliation, as Karen could have explored when she came and gave a talk for us when we were in Lugano, is that there's really not a great coverage of the indolent lymphomas and some of the extranodal lymphomas, so I think the ILROG is going to be looking at that. And then a big black box is how do you combine radiation with biologic agents in lymphoma patients, because they're all on them. So do you sequence, can you do concurrent, is this one safe, is that one safe? What are your actual goals? Is this patient who you thought wasn't curative now potentially curative? I mean, relapse refractory diffuse large B-cell lymphoma, we were like, forget it, you're a goner if you can't get a transplant. Now 40% of these patients are getting cured with CAR T cells. So it's just the whole thing is flipped around, and we just have to adjust to that. In terms of contouring, we're going to do the contouring session after this, but there are some resources available that are coming online through the website and in partnership with eContour and Educase. I would also recommend those of you who have Twitter to do @ILROG team and try to learn radiation, sort of one tweet at a time, as Dr. Tabaja likes to say. And those of you who are trainees, how many residents are in the room? All right, so please, 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 please share with your colleagues that there is an ACGME certified, ILROG-sponsored away rotation that you can apply to on the ILROG website. The ARRPC is involved with this. They helped do the application and hook you up with people. We've had, I think, only one person apply so far. So we really desperately would like people to take advantage of this resource. If you feel like in your institution, your med oncs just don't refer. And I think that happens all the time. But you go out there in real life, these patients may come underfoot, and knowing a little bit about how to deal with them, I think will give you the confidence to practice. I think those are the main things I wanted to talk about. I think that, again, these guidelines have really helped us move radiation to a little more of a harmonized way in the modern era with heme malignancies. They're not perfect. They age fast. And I would encourage those of you who can to actually join ILROG. I think it's free. And then if you want to be like a council member, then you have to pay a certain amount per year, but I think it's free. So please join. The ILROG website is new and improved, so please use it. And hopefully you all got 100% on your SACME. All right. So can we flip over to the contouring part? Oh, wait, hold on. Oh. No, it's okay. So I have one more super important slide. This is not embarrassing Brian Lally, but we actually had several of our prominent ILROG members meet with Bobby Brown at Astro a couple years ago when he was performing this is in San Diego. So that's Brad Hoppy, that's Chelsea Penix, and myself. And this is some guy at University of Florida. You guys know that guy? You guys know Chip? Oh, and then Matt Ning is back there too. I don't know where Matt Ning is practicing now. Okay, now, yeah.
So one other thing I just want to point out is one of the other beautiful things about the ILROG guidelines is that it actually really coalesces the literature. So I'm at my tumor board, and I'm always advocating for the use of radiation for some of these patients as a way to really strengthen their capacity for cure, right? And they're like, well, what data is there for that, right? Because they don't know our literature. And I think that's up to us to kind of be at the table. And so these guidelines really do kind of help to summarize that data. And I just shoot them the guidelines. They're like, oh, great, thank you. And then they're like sending me patients. So it is a way to start kind of building their capacity as well.
Okay. So this first case, can we take all let's take everything off for now. So those of you who submitted contours in advance, thank you. This is great. I love having some, audience participation. But I wanted to go through a nodular lymphocyte predominant Hodgkin lymphoma case. So this is I don't know if we know the age of this person. Aaron's not in the thing, but we'll just make it up. So this is a 35-year-old woman who noticed some left axillary adenopathy. An excisional biopsy showed nodular lymphocyte predominant Hodgkin lymphoma. So is that classic or non-classic Hodgkin lymphoma? Dr. Wright? Non-classic, exactly. So step one, identify this as not the usual thing. So classic Hodgkin lymphoma, that's ABVD and radiation, blah, blah, blah. But non-classic Hodgkin or NLP Hodgkin lymphoma, this is a radiation disease. You should be waving your hand because we can cure it with radiation alone. So this is one of those situations where we're using radiation alone to cure. Okay. So it's involving axillary lymph nodes, and I'm going to kind of scroll up and down here. We have some PET avidity. We have some nodes with fatty hilum, right? We have some other small non-avid nodes that are rounded. So some schmutz a little bit lower down the axilla. Okay, So let's add first the GTV from whoever that user is that put on the GTV. Just pick one, yeah. I think everyone did a pretty good job with the GTV. So this is kind of what we're calling GTVs. Can you all add all the users now, actually? Just want to see if anyone else added some of these other smaller bits. All right, so probably doesn't matter too much though, because do we treat a GTV in NLP Hodgkin? No, we treat a larger mass. So these fields are gonna look a little bit more like the old school involved field, but when you're contouring, you have to translate that in your head. All right, so can we put on the one of the user CTVs? Okay, so I just want to kind of run through this. So for a NLP Hodgkin lymphoma, the volume that we're going after is some elective nodes above and below, and how much above and below is actually not super well defined. So those of you who remember involved field based on bony landmarks, does anyone remember what the bottom field border would have been back in the involved field era? Fourth rib. I think there's a rib one. I can't remember if it was the fourth or the seventh, but there's another landmark that was a lot easier for me to find. So yeah, the tip of the scapula is where you're supposed to put your field border. So that's sort of like, you know, obviously CTV is going to be backed away from that, but this is kind of the old school. So one of the considerations, though, is how do you position this patient? How would you sim this patient? Arms up or arms down? Dr. Lally? Arms up. Arms down? You like arms down? I like arms down for this, as long as you can get it out. In part because the patients that I learned on had arms down, and so that was again kind of what Dr. Beckelman was talking about, the track that I got into. So that's how I learned, was arms down. I don't think there's anything wrong with that. One thing that I would like to point out is if the patient has a PET scan, it might make sense to try to fuse that PET scan in the same position. So this patient had a PET scan with arms down, so I think it makes sense to actually sim this patient with arms down. Okay. Other points. Do you need to include the muscle? So this person here has got a little into the muscle. What do you guys think about including muscle? Is that part of the CTV for NLP Hodgkin case? Yeah, so you probably can trim that back a little bit. All right. So bottom border, can we zoom out a tiny bit? All right, so I really don't know how to count ribs, but if we look for the tip of the scapula, it's somewhere around here. So this person put their CTV down to about the tip of the scapula, kind of covering all of that, coming out, collecting the infraclavicular region, and then they're picking up the supraclav and kind of stopping just below the level of the thyroid gland. So this is actually, I think, a pretty good job. I think, was this the expert contour? Because I really like this one. So let's put on all the, actually just do one at a time so we can kind of just take a look at a little of the sort of the critiques of these things. All right, so this person kind of came out a little more laterally, picked up a little bit of muscle, which again, I think we talked about, and they stopped a little bit shorter. But I would also point out that I don't think it's really completely defined. So what happens if this patient relapses? Where are they most likely to relapse for an NLP Hodgkin lymphoma? Dr. Williams, where's this person most likely to relapse for if you stop at this juncture? Yeah, so somewhere above your field in the neck. You don't know where that might be. So I think if you had to come back and treat this patient, they only had a neck disease, can you still salvage them with radiation alone? Yes, you can. But what are you going to do? You're going to be overlapping on brachial plexus. So I think that's the other thing I like to think about when I'm treating the axilla, how far up to go. So you might say, I'm going to go above the brachial plexus because I don't want to overlap the brachial plexus, and maybe I can avoid the thyroid by carefully constraining it with IM or T. So can we put the expert contour on? Okay. And I will also point out that, this may not be completely the quote-unquote right answer, but the expert definitely came down a little bit further, all right? I think they're trying to follow some of that schmutz, so you can agree with that or not. I'm not going to say this is right or wrong, to be honest. And connecting the volume here, I think that some of the ones that were submitted sort of had separate volumes between the supraclav and the axilla. I mean, I kind of think because this is NLP Hodgkin, even though it is, in some ways we think of it a little bit like a follicular lymphoma because we're using radiation alone. It is like a Hodgkin lymphoma in that its spread is contiguous, so I think it makes sense to kind of cover contiguous nodal groups. So this may not look exactly like, say, breast nodal volumes. I will like to point out that unlike breast, which I think kind of behaves the rules a little bit better, lymphomas do tend to find those weird spots. So, they come out in the fat out here. They tend to be a little bit more generous where they will pop up and recur. So my volumes always look a little bit more generous compared to, say, Dr. Friedman's, who does the breast at Penn. And Dr. Tonk, sorry, there he is somewhere in the audience, right? These volumes look bigger than you would do for breast, yeah. Okay, so the expert kind of came pretty high up into the neck, but looked like we stopped just short of the thyroid gland. So again, bumping up into an OAR. All right, so I think, any questions about this case that you guys want to bring up or ask? All right, so let's do one more case. So we can talk about this next case in one of two ways. We can say this is someone who had a diffuse large B-cell lymphoma of the stomach. Say it was stage 1. They got, say, 6 cycles of R-CHOP, but it was initially bulky. So it was over 7.5 cm, then it shrank down to this somewhat smaller mass in the body of the stomach, and you're using consolidation, you're going to third degree. That's sort of scenario 1. Or we can think of this as a marginal zone lymphoma case, where it's a stomach malt and you're treating to 30 gray with curative intent. So how would those volumes differ if you're doing the diffuse large B-cell lymphoma with consolidation versus the marginal zone lymphoma of the stomach? How would those volumes differ? Anyone? Dr. Wright? Sorry, he's on my service right now, so I can pick on him. So for malt, he wants to treat the entire stomach. Everyone hear that? Okay. And then for the diffuse large B-cell? Yeah, you just treat what was the initial bulky mass. Okay. Thank you, Chris. So I think most of the people who contoured were thinking about malt lymphoma. So I just want to run through these volumes a little bit. So the person here drew a GTV in blue, a thickened amount of stomach, okay? And then I think what we're calling this pink volume, I think would be what you might call a CTV if this was diffuse large B-cell lymphoma. And then we're missing, can you put on this CTV for this user 2? TV. The points of debate is how much pylorus do you include, right? So they're kind of a little bit shy on the pylorus. TV expansion, which you can see is asymmetric. How do you guys go from, say, a CTV, what's your typical way of doing that? Dr. Green? And actually either measure it and do an expansion, or you can even adjust your contours to see how it's moving. So that's approach number 1. Say this person, then how would you make an ITV? You're looking at me funny. Do you need an ITV if you're doing breath hold? TVs if you're doing breath hold? Is in breath hold. So you could do 3 breath hold scans and sort of Boolean those together. Or you can just do an arbitrary expansion. But I think that most people who don't live in a proton world and you plan on PTVs, you're just I'm going to include that PTV. So I think that's reasonable. All right, so how would you to come in for the day of SIM? Long. I hate 4 hours. You know why? Because they lie and they eat very big, bulky breakfasts of grape nuts and stuff like that expand, I just say overnight. And I said, forget it. This, for a gastric malt, this is not an urgency. You find a time that you can come in the morning, and our CT schedulers will find time. I just do overnight. I've gotten burned enough times with 4 hours. So yes, I know that's what it probably says in the ILROG guidelines, but I say for my own empty. What about? Do you really want to distend the stomach if you're trying to treat a full stomach? I mean, the entire stomach?
We simulate it with both full and empty stomach.
Okay.
But we try to treat with an empty stomach.
Oh, okay. So you do two sims. Yeah. No, I know, but this is an interesting idea. Because I think the issue that
Tell me to sim them both ways. Am I wrong?
I usually don't do that. I just say stomach empty and only do stomach empty.
They're saying them both ways, don't they?
So we give them 50 cc's of oral contrast just to kind of see better where the stomach is, but very low volume of oral contrast. This person had the oral contrast, so the contrast is down their gut. So I think if you are going to use a small volume of oral contrast, you should do it right before they get scanned. But I think one of the points that Dr. Lally is bringing up very importantly is that the stomach will vary in size over the course of time, and using things like CBCT can be helpful, but we do tend to use just larger PTV expansions to take into account not just the movement that you get from breathing, but that the changes in the stomach size based on just different days. I mean, even if it's empty, it can move around quite a bit. So yes, I've been burned before, but I do like using CBCT. Can we put on some of the other contours, the other CTVs? I only have 9 seconds left. Okay. Yeah, so I think submitted contour job, a CTVing for a gastric malt. Can you put on the proximal duodenum, like the entire
Here we go.
GRT.
case?
Actually,
All the time, but I'm very tight about my low dose to the lung. So one of the things in that thing was the V5, so V5 less than 55% is what I use. So even if I'm doing like an upper mediastinal case, it might look very close to APPA, but I use IMRT in the mediastinum pretty much routinely. And then for IGRT, I think it depends a little bit on how much dose you're getting with your CBCTs. I tend not to do daily CBCT. Some places do. I like to do at least once a week CBCT for like the young mediastinal lymphoma cases.
and for the stomach as well, would you be?
For the stomach, I like to do CBCTs every day.
And with IMRT.
And then I usually use IMRT. These cases can be done adequately with 3D conformal as long as you're using enough beams. But just because we try to keep the dose of the kidneys and liver lower, IMRT usually does a pretty nice distribution. You just have to make a very big PTV expansion. So like in the neighborhood of like 2 cm PTV expansion.
Thank you.
One quick question.
Yeah, so I think you got to definitely pick your battles. So for upper mediastinal cases, APPA is actually generally okay. For stuff in the head and neck, I do try to push for IMRT. I do make the point that unlike a lot of patients with solid tumors, these patients are going to be living decades with the side effects, so that's one of the points they usually make. I would say most cases we end up treating with IMRT. I think it's maybe 10% or less that we can't get IMRT approved and we use 3D.
Great. Awesome session.
Thanks,
Thank you. So it's lunchtime. Just a couple quick housekeeping notes. So for lunch, there's the lunch for everyone in the exhibitor hall. There's also the Susha Asbel Women's Forum and lunch. And there's also a satellite symposium with Blue Earth Diagnostics, so please choose amongst those. Also, we've increased the bandwidth of the Wi-Fi service, just so that you're aware a little bit better. It may not be perfect, but there are a lot of folks who are logging into the system. If you're having any trouble with the SAMs, please do go to the registration desk for help. Just as one point, you cannot preview all the questions and then go back and make the answer. Once you have gone through one question, you can't go back. If you have done that, it's okay, it can be refreshed. Please go back to the registration desk and they'll help you. And what we're going to try and do for upcoming sessions is before the session, show what the questions are on a slide, okay, so that everyone can preview. This is just one of those things with the app, because if you could go back, you in theory could change your answer, and they don't want us to do that. So if there's any questions about SAMS, though, registration desk, please enjoy lunch and see you in the afternoon.